All parking issues and technological issues have been resolved, so we'll go ahead and get started. We'll begin today's event entitled What Explains the United States Dismal Maternal Mortality Rates? My name is Sandeep Badala. I am the Senior Program Associate with the Maternal Health Initiative here at the Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, where we work to identify challenges and discuss strategies for improving maternal health. I'm sorry, did I say Advancing Dialogue on Maternal Reproductive Health Series? I meant Maternal Health Series in case I did that, but we know how closely those two issues work hand in hand. The series is generously supported by the Maternal Health Task Force as well as the United Nations Population Fund. As many of you know, the Wilson Center aims to bring the worlds of policy, practice, and academia together. For the second year in a row, we were voted the top think tank to watch in the U.S. and among the world's top 10 think tanks. Speaking of watching, today's event is being webcasted live, so what that means for those of you in the room is that when we get to the discussion, I'd ask that you use a mic, and please introduce yourself and your affiliation so those tuning in will know. I also wanted to mention the Twitter handle for today. It's #MHDialogue. And the Wi-Fi password, if you need it, is on the wall. If you do attend our events regularly, it is updated regularly. So if you're having difficulties, please consider reloading your username. That might actually solve the problem. So before I turn to our esteemed speakers, we have a quick video to get us started and talk to us a little bit about maternal health issues in the United States.
Birth to my younger sister. I think I felt the burden of what that void would be like. So I often say, what would you be doing? Actually nearly died in childbirth when she was giving birth to my younger sister. I think I felt the burden of what that void would be like. So I often say, what would you be doing today if you'd lost your mother in childbirth? And would you be who you are? Maternal mortality globally is coming down, but it's not coming down fast enough. And so that's why Merck joined the fight. When people think about maternal deaths, they think it's happening over there in the developing world. The US, a country that spends over $50 billion in childbirth-related care, is one of only a handful of countries where maternal mortality is on the rise.
I have to say that maternal mortality can affect any person that goes into labor. The three biggest causes in a preventable death: hemorrhage or blood loss, hypertension, increased blood pressure, or venous thromboembolism, more commonly known as a clot in the lung. For many areas in fetal medicine, we have standardized operating procedures. And yet, until recently, there's been a big reluctance to have standardized protocols for maternal care. I honestly felt, as a woman leader in obstetrics and gynecology, if I didn't do anything about it, I could not expect anyone else to.
We do a lot of work in terms of trying to save babies. But if you're really going to save babies, you really got to improve the health of mothers. And so with our relationship with Merck for Mothers, we now have opened up a new strategic front.
Part of the Merck for Mothers initiative here in Central Harlem is the role of community health workers. And community health workers address the behavioral, social, and environmental issues that residents face in their community that can't really be addressed in a clinical setting. There seem to be a lot of gaps when it comes to where women and how women get information.
When it comes to pregnancy, a woman should be driving her care. She needs to be empowered with the information to make the right decisions.
If we don't support the women in this community, the whole community, men, children, family members, fall apart.
We are on a path to success. Let's not change it.
Learn about maternal mortality, know how it's impacting your community, and start the conversation. we can end this preventable tragedy, and I'm hoping we can do it in my lifetime.
So I think we should listen to Priya. She said, let's discuss this. So let's go ahead and do that. As those of you who attend our events know, that we often focus on these issues at a global level. So when the Maternal Health Task Force approached us and asked us to host a dialogue on U.S. rates, I have to say personally that I was really excited by that opportunity. I think there's a lot to learn and a lot to discuss. And one of the things as I was thinking through this and preparing for this is that, in our discussions, we talk a lot about data and how important it is to have good data in order to make the policies and programs to help address these issues. And so I ask that you join me in thinking through that as we have today's dialogue. And also, I know we are talking about maternal mortality rates, but we all know where there's mortality, there's often morbidity. So that is something, or there is morbidity. That's something also that we can consider as we have these conversations today. We are going to first hear from Dr. Liu. He's the Associate Administrator at the Health Resources and Services Administration with the U.S. Department of Health and Human Services. And he's going to talk to us a bit about health system responses to these issues.
Good morning. Can you hear me? I'm delighted to be here. I'm very honored to be invited to speak at this meeting. As you all know, each year in the United States, more than 600 women die from pregnancy and childbirth, and more than 50,000 women suffer a life-threatening complication, or what we call severe morbidity. We are the richest nation on the planet, and yet we consistently rank near the bottom on most standard measures of maternal and child health, including maternal mortality. But it wasn't always like this. In the 50 years between 1935 and 1985, maternal mortality in the U.S. actually decreased by 99%. So this was hailed as one of the greatest public health achievements in the 20th century. But then it started to go back up. Between 1987 and 2011, maternal mortality ratio more than doubled from 7.2 to 17.8 per 100,000 live births. A maternal mortality ratio is only the tip of the iceberg. For every maternal death, there are 75 to 100 women who suffer a life-threatening complication. Severe morbidity also doubled between 1998 and 2011. So if you're wondering what's going on, now we know that some of this could be due to better surveillance and data reporting with the adoption of ICD-10 in 1999 and a pregnancy checkbox on death certificates in 2003. But many of us do worry that this rise is real. We know that the demographics of childbearing in the US is changing, that more older women are getting pregnant, and more women are entering pregnancy with chronic conditions like hypertension, diabetes, or obesity, which has more than doubled in the last 20 years. Today, more than half are overweight, and about 1/3 are obese. Now, obesity is an important risk factor for some of the leading causes of maternal mortality, including hemorrhage, preeclampsia, and thromboembolism. Also want to call your attention to cardiovascular diseases and cardiomyopathy, which are becoming the leading cause of maternal deaths in the United States. In 2011, they accounted for about a quarter of all maternal deaths in this country, while 4 other causes, hemorrhage, infection, preeclampsia, and thromboembolism, account for nearly half of all maternal deaths. Now, cesarean deliveries may also play a role, and cesarean has been on the rise. In 2013, 1 in 3 babies born in the U.S. were delivered by cesarean. That's nearly 1.3 million cesarean deliveries that year. But what's troubling to me about all of this, what keeps all of us up at night, is the persistent disparities, racial, ethnic, socioeconomic, and geographic. Today, African American women are still 3 times more likely to die during pregnancy and childbirth as a white woman. And it's a gap that we haven't been able to close for decades. We really can do better than that as a nation. So what can we do about it? So when I came to the Maternal and Child Health Bureau about 4 years ago, I was dismayed by just how little we as a bureau were doing around maternal health. So wanting to put the M back in MCH, I reached out to our partners. I really want to give a shout out to a number of our core partners. They really came together around this issue. There was never a question of credit or turf. They just want to do something about maternal mortality in this country. And that's how the Maternal Health Initiative was born. So in 2012, the group conducted listening sessions, town hall meetings, webinars, and a common vision about a framework for a national strategy on maternal mortality and morbidity was formed, with these 5 key strategic priorities: improving women's health not only during those 9 months of pregnancy, but before, between, and beyond pregnancy; improving the quality and safety of maternity care in the United States; improving systems of maternity care, including public health and clinical systems; increasing public awareness and education; and improving surveillance and research. And let me just spend a few minutes on these first 2 about improving women's health before pregnancy and improving the quality and safety of maternity care. So first, if we're going to move the needle on maternal mortality, we really have to first improve women's health, again, not only during pregnancy, but before, between, and beyond. And of course, the game changer for women's health is the Affordable Care Act. The Affordable Care Act is perhaps the most important women's health law in the last 50 years. Women can no longer be denied coverage or charged more just because of their gender. More than 7.7 million women under 65 sign up for health insurance coverage during the first open enrollment period. More than 1 million women between the ages of 19 and 25 who would have otherwise been uninsured now have coverage under their parents' plan. As many as 65 million women with pre-existing conditions can no longer be discriminated against or charged higher premium for health care coverage. And an estimated 8.7 million American women with individual insurance coverage gain coverage for maternity leave or maternity services because of the health care law. And an estimated 55 million women with private health insurance now have access to recommended preventive services, again, not only during pregnancy, but before, between, and beyond pregnancy, including well-woman visits, contraceptive counseling, HPV testing, breastfeeding support, supplies and counseling, and screening and counseling for intimate partner violence, which provides this extraordinary opportunity to improve women's health, not only during pregnancy, before, between, and beyond pregnancy. Second is to improve the quality and safety of maternity care in the United States. We all know that there's plenty of room for quality improvement in the care of pregnant women that they receive in this country that can make a real difference in maternal mortality and severe morbidity. So in 2013, we supported the Council on Patient Safety in the creation of patient safety bundles. These bundles are best practices, guidelines, checklists, protocols designed to improve patient safety and quality. We know that these things can make a difference. So for example, in the United Kingdom, after the publication of the thromboprophylaxis guidelines by the Royal College of Obstetrics and Gynecology in 2004, maternal deaths due to thrombosis and thromboembolism decreased by 60% in just 3 years. 8 bundles have been developed for some of the most important causes of maternal mortality, including hemorrhage, preeclampsia, and thromboembolism, and 2 more are under development. But these bundles will remain bundles unless they're actually implemented and integrated into practice. And that's why earlier this year, we launched a new campaign, which initially I had wanted to call it 100,000 Mothers campaign, patterned after the Million Hearts, except that it probably would have taken me about 2 years to get clearance for that. So we just decided to go ahead with calling it AIM, the Alliance for Innovation in Maternal Health, that's led by ACOG, but again, including a kind of wide coalition of partners. And the question is, can we save 100,000 U.S. women from deaths and severe morbidity over the next 5 years by doing three things really, really well? First, improving women's health, again, not only during pregnancy, but before, between, and beyond pregnancy. Second, reducing low risk and unnecessary cesarean deliveries. And third, and probably most importantly, improving the quality and safety of maternity care by getting these safety bundles into every single birthing hospitals and facilities over the next 3 years. Now, with respect to the first goal, improving women's health and before and between pregnancy, the focus will be on improving access to and content of and quality of preventive services, including preconception and interconception care, and also the postpartum visit. With respect to the second goal, reducing low-risk cesarean, the immediate focus will be on developing an evidence-based bundle on reducing low-risk, what we call NTSV cesarean deliveries. And with respect to the third goal, getting the safety bundles into every practice in America over the next 3 years, we know that these bundles work. I actually saw it work firsthand when I was out in California. I saw a network of really dedicated doctors, nurses, public health professionals. They went around hospitals around California. They did grand rounds. They provided in-service for labor and delivery staff. They initiated quality improvement initiatives. They engaged hospital CEOs in changing hospital practice. And they're beginning to move the needle. Up until about 2006, California trends were trending along with the United States. The maternal mortality ratio just kept going up. Then the curve began to bend. California's maternal mortality ratio went from a high of 16.9 in 2006 down to 6.2 in 2012. That's about a 60% reduction in just about 6 years. African American maternal mortality ratio went from a high of 52 in 2006 down to 28 in 2012. And if this can be done nationally, if we can replicate this result nationally, and that's why we launched the national campaign, that we will go from about number 60 in the world down to close to top 10 in the world. So we truly believe that this is a needle that can be moved. This is a gap that can be closed. And so if you want to learn more about this, Jeannie from ACOG shares, and the ACOG folks are really been championing, driving this initiative, or you can contact me directly. Here's my contact information. I'd be happy to talk to you all more about this initiative. Thank you.
Thank you, Michael. I think you brought up some, certainly some key points there, talking about disparities within and among populations here in the United States, and also issues around quality. And it was really interesting, I know, for me to see the graphs around California, as well as around race and ethnicity. I think the visuals can often really concretize what we're talking about. You also brought up non-communicable diseases quite a bit, and in case you all didn't notice, on November 30th, we're actually hosting an event, a full morning event looking at non-communicable diseases and maternal health, and we'll be honing in specifically on diabetes. And so we should make sure that we don't have any cookies that day, Francesca, because we did host an event, I don't know if you all were here a few years ago, on nutrition and maternal health, and had chips. So I'm a little bit more conscious of that this time around. So no cookies at the diabetes event. We are now going to hear from Bette Begleiter. She is the Deputy Executive Director of the Maternity Care Coalition, and she's going to talk to us a bit about community responses to these issues.
Hi. About every 3 months, the Maternal Mortality Review team gathers in West Philadelphia at the Office of the Medical Examiners. And this group is made up of healthcare providers, maternal fetal medicine specialists, the OB chairs, of the 6 birthing hospitals in Philadelphia, midwives, nurses, EMT, emergency housing, child welfare, and a community-based organization. And our task at each meeting is to review somewhere between 3 to 5 cases of women who have died related to basically within a year of giving birth or while pregnant. And we did that last month, and we had 5 cases, which was a lot, and there was a chilling similarity between these cases. Many of those women, in fact, all of those women, had interacted with many of the institutions and systems that we represented. All of them had substance abuse problems and had multiple experiences with treatment. 3 of the 5 had been under child welfare supervision as children. 2 had been under child welfare supervision as mothers. There was multiple hospitalizations for drug treatment. 4 of the 5 had behavioral health issues. Maternal mortality looks different in the U.S., and I think it really became crystal clear to us in a way that we hadn't seen it so boldly painted as that day. Let me give you some context. And what I'm here to talk about is a community response, because the point of meeting every 3 months is to figure out what we as a community can do. I work at Maternity Care Coalition. We're community-based organizations. We work with low-income moms and their babies in the greater Philadelphia region. And we do a lot of our work in Philadelphia. Not everyone knows, but we have the highest poverty rate of the 10 largest cities. And over a third of the children live in poverty. 2/3 of our births are Medicaid. And we also have really alarming racial disparities. That you can see them in the infant mortality, and they are our worst racial disparity is really in maternal mortality, where 4 times as many black women die as white women. This past spring, we, after much work, were able to release a report on maternal mortality in Philadelphia, and it covered the years from 2010 and 2012 and certainly supported what we were learning, what we've been seeing in the cases that we've been reviewing. If you look at the 55 deaths that we reviewed, what you'll see is that almost half of them were for non-medical reasons. And as you can see, that of the deaths that were due to natural causes and could be seen to be related to pregnancy-related causes, only 1 of them was determined to be preventable. But if you look up there on the non-medical, what you don't see on this particular slide is 2/3 of them involved substance abuse. And clearly, the women who died were disproportionately black, poor, obese, and HIV positive. And for that period of time, our maternal mortality rate was 50% higher than the national average. We had the good fortune to have Merck approach us. It was about 3 years ago, and sit down with us and say, well, what's going on in the U.S.? We know something, we've been very focused globally, but what do you think is going on? And they also offered us something that has never happened to me in my 35-year career as a social worker. They said, we want to give you a creative space to figure out what to do about it. So that was very unusual. And so we...
Congratulations.
Yes, really. I still haven't quite absorbed it. It was a unique experience. And what we did was we gathered together a community advisory committee, and that was made up of OBs, maternal fetal medicine people, a lot of the same people or people like the people that are on the maternal mortality review team, but also community people, midwives, nurses, to really try to figure out what do we need. And we decided to pilot an intervention. We're a community-based organization. We wanted to see what could we as a community do. And one of the first people that walked in our office was someone who we called Jessica, and she presented with a very full range of issues, including the fact that she had had no prenatal care. She had no idea how pregnant she was. She had substance abuse. She had no stable housing. She had basically lifelong behavioral health problems, among many other issues. And we realized that to get Jessica from pregnancy to a healthy outcome, a lot had to come together. She was receiving her care in 3 different hospitals. If you've ever been to Philadelphia, we do not have the greatest public transportation system. It's not easy to get between them. She needed to get stable in stable housing. That involved the housing offices. She needed to get substance abuse treatment that stabilized her as well. Her hypertension had to come under control. There was a lot that had to happen. And like many urban areas, this is very fragmented in Philadelphia. And we realized that in order to get Jessica healthy, what we really had to think about was systems transformation. And that given this creative space, the need for systems transformation, that we had the opportunity to do something really important. And we came up with our vision of what had to happen. And key to that vision was thinking about this from the perspective of the woman. Because each of these systems are set up in ways that make a whole lot of sense for them. But in terms of the woman's experience, that was not the case. And so we came up with a vision to be a consumer-friendly, culturally responsive, seamless, and transparent system of care that would support high-risk women. And we worked both with our community advisory committee, but also our staff in developing the model. And we piloted it, and we are now implementing it. And we are 7 months in to doing this. And the vision that we've had was really to create a community-based response, the core of which is a community health worker who works with the woman and has the cultural competence to make that connection very, very quickly. It helps address the barriers that people have in terms of navigating those systems, educates. We added patient navigation. This isn't something we had done. We've done home visiting for close to 30 years, but we hadn't done the patient navigation. But we knew we had to be in the office with the woman so that we could help support her understanding of what happened there and figure out how she can see it through. As well as we adopted a patient activation model. You guys may be familiar with it, but there's a lot of literature on it. I took out that slide because I had too many. But it really, the point of it is to really empower the woman and have her take responsibility for her care and for her treatment. And the other piece that we realized we had to do, because we tried doing it without it, is that we had to have a clinical partnership. That if we really were going to test this model and really have systems transformation, we needed somebody with us who believed it and who we could work the kinks out with. And we found that with the Hospital of University of Pennsylvania, who we call HUP in Philly, and one of the OB, actually a maternal fetal medicine specialist, had been on our advisory committee. And she stepped up and said, we really want to do it. And we went with them because they really believed in the model. They believe in community health workers. They are very, very large, busy urban clinic in a large academic center. They struggle with no-show rates. They have complete overutilization of their emergency room, and really understand that what they were doing in the hospital was really not enough. I have to tell this anecdote. I recently had an interaction with one of our staff, and there was something she hadn't completed. And she said, well, I sent that person 14 emails, and they never responded. And I said, well, probably after the second or third email, you got to figure out there's something else you got to do. Maybe something different. And I think that's what's happening with our hospitals, is they are realizing that if they get the woman into the hospital, they're extremely successful. We only had one death that was preventable. but they have to look outside the walls of the hospital, and they are not the experts of that, and they're realizing it. In addition, in terms of really getting people health care, it has to be more than the hospital, and we realized we needed a Medicaid managed care company that would work with us. We went with the largest one in Pennsylvania, Keystone First, so that we could coordinate care, as well as a community behavioral health partner, because it was key that people get the care. We had the experience during our advisory committee where literally on one side of the table was our providers, and the other side of the table the managed care companies, and we talked about the need for this, and the providers say, well, you never call us back. And the Medicaid managed care company said, I call you all the time, you never call me back. So we figured we could bring everybody to the table. It was ambitious. This kind of complicated slide sort of shows you all of the people involved. We have a leadership partnership that involves leadership from managed care, behavioral health, maternity care coalition, where we look at the strategic issues of this partnership. And then we have an intervention team and case coordination on the ground. And the Medicaid managed care company for this particular project gave all of our clients the same case manager. We have a care manager and a social worker at the clinic who works directly with them. They meet at least weekly. In addition, there's a weekly meeting with the medical staff to review cases so that we can tell them what's going on. They had one patient who they were really angry at, and it's almost all residents who give the treatment, and they were very angry because she was not following through on her medication. Well, we were able to let her know that she couldn't get her pharmacy to fill the prescription given the way that it was written. It took intervention with the pharmacy, it took intervention with the managed care company to get her on auto renewal, and all of a sudden she was a compliant patient. Another client of ours who was diabetic and homeless, when she had a really difficult time getting into housing, she just kept giving up after 2-hour waits. So our advocate, that's what we call our community health workers, our advocate went down with her, got her into housing, but it was a rehab setting because that's all that was available. They wouldn't let her bring sharps in for her insulin. So we had to intervene with the head of the, we worked our way up. We had to get to the executive director to get permission. So those kinds of things that end up having the women that we work with give up. With all of us working together, we're able to get them through. And in addition, we also included a doula service for our clients. So we are there from beginning to end. We find a lot of the women we work with end up with unscheduled C-sections, and we're with them there throughout to help them figure out how to get through. We work with women from pregnancy until the baby turns 6 months, because we want to our goal is to get them to reach a point where they can figure out how to manage their chronic health condition and being a mom and working and all the other things that they have to put together. We're now seeing that we probably need to stay with them longer. In addition, we want to educate the community on maternal mortality and morbidity. We were very active when the report came out in getting that report out into the media and into the public's attention. And we are working with managed care organizations to try to bring more sanity to the system. One example I can give you is that we've all discussed, people really understand they've got to screen pregnant women for perinatal depression. The women that we work with receive that screen at HUP. They receive it multiple times from their Medicaid managed care company, and we do it as well. We should be able to figure out how to share that information. And we are also working on a policy level to get the kinds of service that we know these women need supported by Medicaid managed care. It's great that ACA covers private insurance breastfeeding support. Medicaid does not. They will cover the pump. So we're working. We met with the head of medical assistance in Pennsylvania. He was very open to the idea of supporting community health workers, and he was open to the idea of doulas. and breastfeeding support. So we're hopeful that that will change. So we still hold on to our vision for success. I'd love to come back in a year or two and tell you how it's going. But I think what's really, keeping us really very excited and feeling really positive is that despite being in this busy urban clinic where the residents change every few weeks and we have to reintroduce ourselves and reintroduce the program to, the doctors are very excited about it because they see the changes that are happening in their clients, in their patients. They're coming in for visits. They have a less than 50% show rate for postpartum visits. Ours is close to 100%. So we know this can work, and we are really looking forward to showing that we can have a model of systems integration that really serves the needs of this very high risk and vulnerable population.
So I don't know if any of you were a few minutes early, but you may have noticed that I was speaking to Bet about my experiences. So hopefully the bangs throw you off. But about 20 years ago, when I was in graduate school for social work, actually, I did. I was working in a prenatal clinic in Camden, New Jersey, which is about 5 miles from Philadelphia. So deals with a lot of the issues that Bet brought up. And we had some similar programming, both working on Healthy Start. And I will tell you, I know you're excited to come back in a year or two and talk about what's changed. I can tell you, gosh, is that 15 years or so later? We weren't talking about doulas back then. We were following 6 weeks postpartum. We weren't following 6 months, and you're talking about the possibility of going longer. So if you really want to talk about growth, I mean, I can tell you just listening to you and knowing the communities that you're working with, how much has changed. And so, there was no Affordable Care Act. And so just even what your comments about breastfeeding support, I hope it is coming because a lot has changed and there's a lot to be proud of. Of course, there's a lot more work to happen as well, but definitely some successes to celebrate as well, listening to you speak. It's very different than when I was doing that that long ago. So we are going to, actually before I introduce our next speaker, there might be a Barbara in this room that has an Apple device that's spewing malware. It's corrupted, so just wanted to point that out, and not to call you out on that, but just so you know, I did hear from some colleagues that you might want to be aware of the situation of corruption with your device. So, Monica, I think it was completely your fault, by the way, that I, in my introductory remarks, thought that maybe I said reproductive health. I think I was thinking about your title. Monica Simpson, she's Executive Director of Sister Song. That's a national women of color reproductive justice collective. And she's going to talk to us a bit more about the reproductive justice movement and work around these issues, especially as we were hearing a bit already about some of the issues around women of color in various communities with regards to disparities in this country. So thank you.
Thank you. Good morning, everybody. I'm hoping I can get this up here, and it will all stay. I already made one boo-boo this morning and spilled water all over that table, so I'm hoping not to knock a microphone off or something like that. But it really is an honor to be here today and to be able to speak with you all for a few moments on reproductive justice and our approach to really tackling this issue of maternal mortality that is definitely something that we all should be talking about and so many more communities should be talking about as well. So I want to start with a bit of a story for you all that kind of got me really paying attention to these issues. So my little sister gave birth to a beautiful young boy. His name is DeMonte, and he is like my heart and joy. And I feel like we're like connected so deeply because I think I even knew my sister was pregnant before she did. Like I was telling her like, I think you're pregnant. And she's like, no, I'm not. And I'm like, I think you are. I took her to the doctor and she was pregnant. Like I just knew that he was coming into this world. And I was really excited because I was able to like be her assistant during her birth. And I got to, go to doctor's appointments and hear about all the different things that were happening with her body. And I was really excited to be there for the birth. So I remember the day that I got the call when I was at work saying that, hey, I'm in labor. And I'm like, let's go. It's time to get this thing going. The baby is coming. And I get there and there's complications. They're telling us that the baby's heartbeat is dropping. They want to move my sister very quickly into a cesarean. That's not what she wanted. And so I'm trying to be an advocate for her, saying this is not the type of birth that she wants. She doesn't want to be cut open. Like, listen to what the mother wants. And they had no ear to that, the doctors at the time. And we live in a very small southern city in North Carolina. This is where I was at the time. And just she had no say in how she actually wanted to give birth to her child. It was the first child too, so she's scared. It's my first time being in a room with someone, right? And in the midst of labor, I'm scared, but I'm trying to advocate for her, and I didn't have the knowledge at the time to really be able to be a strong advocate for her. And so she ended up having a cesarean, and luckily, she was able to come through that well, and my nephew was here and beautiful, and the family is great. But for so many women, especially Black women in this country, that's not always the way that the story ends. It's the way that the story starts sometime, right? Where, they're kind of being pushed into these cesareans or pushed into delivering in ways that they don't necessarily want to, or not having the support system that they need to be able to have that healthy pregnancy and to be able to deliver a healthy child. And so at that moment, that was a turning point for me in my activist life, and to really start to pay attention to how this was showing up in the lives of the women in the communities that I cared about so much. And so I said, well, I need to get some education for myself. And so I moved into saying that I wanted to be a doula. I want to be able to know all that needs to happen. I want to be able to really be able to be a strong advocate. And so I moved forward in that and became a doula. And right at that time, I was also working very deeply with Sister Song and the reproductive justice movement. But that's what really brought me to this space and brought me into this moment, was actually being in that room and being in that moment where it was so difficult for someone to be able to get the desired result that they wanted. And I made a vow at that point that I would make sure that I had all the education that I needed to make sure that that did not happen to anybody else that I knew. So, reproductive justice. Maybe a new term for some folks in the room. How many folks have heard of reproductive justice? That is great. I don't have to do this long spiel about it, right? Because a lot of folks do know about the reproductive justice movement.
But those online might not know.
But those
so,
online may not know. I keep forgetting I'm not just talking to the room. There's folks out there. What's up, everybody? So the reproductive justice movement, we celebrated 20 years in 2014. It's a movement that was created by Black women in 1994, and it was really rooted in this human rights framework too, right? Because these women of color were going to these international meetings. They were, really talking about reproductive health and rights on a global level and really learning a lot of strategies from what was happening all across the world. And they wanted to bring that back to the U.S. And so in 1994, right after the big Cairo meeting that I'm sure a lot of folks in the room know here, right? There was a lot of energy that came out of that meeting. It was one of those transformative kind of movement moment kind of meetings. And so these Black women came back to the U.S. and said, okay, if we're able to really start to make these linkages on an international stage with reproductive rights and, social justice issues, then why can't we do that at home as well? And this was also right at the height of the healthcare reform that was happening during the Clinton administration. So they're like, well, this is really a time for us to start to make this linkage, right? It's really a time for us to start to talk about how we center the most marginalized communities when we're talking about access, when we're talking about healthcare, right? And so these Black women called themselves originally Women of African Descent for Reproductive Justice, and that was the first time that the term was ever used. And this framework was really kind of of pushed out into the world by Sister Song, and really articulated as this intersectional framework that really looked at how all of the different parts of us kind of show up and how it's important for us to be able to embrace all of those different ways that we show up. Audre Lorde has this amazing way that she puts in, I feel like it's like one of the most clear and concise ways to talk about reproductive justice, right? And she says that we can't have a single issue movement because no one lives single issue lives, right? And so very, very simple, very easy, right? And that's exactly what the reproductive justice framework is about, because reproductive health and rights at the time was really focusing on how do we make sure that abortion access to contraception is something that is something that everyone has access to, something that we're able to like make sure is in place and we can move forward on. And that's something that we always really continue to keep central in our work. But the reproductive justice framework says it's not just about the right to not have children, right? It's also about the right to have children. And it's also about the right, the human right, to also parent those children in healthy and sustainable environments. And it really is about this overall notion of like our human right to self-determination and bodily autonomy. So it really was about expanding the analysis from just like this pro-choice, very kind of single issue lens to really incorporating a more intersectional way that we saw our whole lives, right? And that's really what reproductive justice is about. And so for us in the movement, because we're not just only focused on the right to abortion, and we're also looking at how do we create healthy families and have healthy lives, this conversation around maternal mortality and the fact that it's overwhelmingly impacting Black women, marginalized communities, women of color in this country is something that we definitely had to start paying attention to. So you all have heard from great folks on the panel already around with great statistics. So I'm not going to give you so much more of a statistical kind of conversation, right? We know that the U.S. is one of the only 17 countries worldwide and the only country with an advanced economy where the rate of maternal mortality is rising. That's pretty bad, y'all. It's just, there's just no other way to put that. That's really, really sad for us to have to say that out of our mouths in this room, right? We've heard from the panel already that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women. And Black women in the South, though, experience poor maternal mortality outcomes in Fulton County, Georgia, which is where I am based and where Sister Song's headquarters are, which includes the largest city of Atlanta, right, has a maternal mortality rate more than 3 times the national average. And in Mississippi, from 2010 to 2012, the ratio statewide was 55 deaths of Black women per 100,000 live births compared to 29 deaths of white women. So these two states in particular is where we're seeing like the rates of maternal mortality rising the highest. And we wanted to know why that was the case. Why is it that Black women in the South are dying at a rate so much faster than white women? So we partnered with the Center for Reproductive Rights in 2014 to create this report. I have a couple of reports for folks in the room. It's called Racial and Gender Discrimination in the U.S. Healthcare. And I want to read a couple of the stories that we were able to bring together out of this report for you very quickly. So when we talk about the fact that there is a lack of access to information on sexual and reproductive health, this is what one of the participants in our focus groups that we were able to pull together in Mississippi and in Georgia said. When I was younger, the stigma prevented me from buying my own condom. So you had to remind the guy to have a condom. You couldn't really talk to your mom about it. So far as family planning went, I'd whisper it to my doctor when my mom wasn't in the room. And then I would try to do as much as I could on the sly without getting caught, which means most of the time it was pretty unsafe and dangerous. Georgia teaches abstinence more than sex education. I learned to say no a lot, but we didn't really learn a whole lot, such as yes to sex. If this could happen, then yes, this is what I need to do to protect myself. I'd say I had more abstinence training than sex education. Another one of our participants in the focus group talked about discrimination in the healthcare system. And so her story reads, the school clinic is prohibited from giving out condoms, and they couldn't provide any birth control. The school district prohibits them from giving out birth control. I remember I went and talked to the nurse practitioner, and the nurse told me that if kids come in and ask for condoms, she can't give them to them. In fact, the kids couldn't ask for condoms at all. So she went as far to throw them out on the floor and say, well, if you find anything that you need before you leave, feel free to pick it up and take it with you. Another participant said, I got my first yeast infection and did not know what to do. I thought I had a full-blown STD, and I didn't even know what it was, and so I let it go as far as I could let it go, to the point where I could barely sit down. I couldn't tell anybody because I was terrified. Then I came back from the drugstore with yeast infection medication because I thought maybe I should try that, and it went away within 3 days, and I thought, all right, now I know what a yeast infection is. And the last story I want to share also speaks more to the racial discrimination that shows up in our healthcare system. My daughter, my fifth daughter, was born with deformities. She had conjoined fingers and she had an extra finger on one hand, and she only had 2 toes on her left foot. When they saw her, they made assumptions. Of course, I'm black, I'm young, it's my 5th child, I'm under 25. The assumption by the hospital staff was that I must have done drugs. The reason I know that was because as soon as I woke up and got out of recovery, they questioned me about drug use. They came in and did 2 blood withdrawals. It made no sense to them to do it, but they refused to let me have my baby for 5 hours. Finally, because they probably thought it was a fetal alcohol syndrome baby, they thought I had done drugs. Finally, they let me have my child. And before this, they questioned my mom about whether or not I had done drugs, and then questioned my boyfriend about whether or not he had done them as well. So we gathered these women together in Georgia and Mississippi to hear directly from those most impacted, right? Because for us, the approach to actually starting to really break this issue down definitely has to start with our, it has to start at the grass house. We have to start with those who are doing this work, the doctors, the nurse practitioners, all those folks who are really kind of involved in making sure that women are actually having healthy pregnancies and healthy births. But we really wanted to get to the root of the issue and actually have conversations with those most impacted. And so to bring this report to fruition, which we were able to take to Geneva to the CERD committee, the Committee on the Elimination of Racial Discrimination, we didn't just want to talk about the statistics. Those were easy to find. You can create a table all day long and we can see the numbers going up and we can see where all of those things land. But what we really wanted to focus on was we wanted to make sure that the voices of those most impacted actually were able to be brought to the forefront. And that's what really brought this report to life. Not just the statistics, but actually listening to those that were most impacted. And that's the approach that we take, because despite the clear evidence of a crisis in maternal mortality, there is little consensus on the causes of the problem, right? So for us, it's like, how about we go to where the problem is, right? Sounded very simple to us, right? So we discussed like the different ways or the different reasons as to why, and this was showing up in our communities, and we got these reasons from those who were the ones who were actually most impacted. The first being the fact that racial discrimination is still very much real in the healthcare system. The fact that these women were not able to go into a healthcare provider despite their economic status, despite their education level, they were still getting barriers put up for them when they were actually trying to get the information that they were supposed to have to be able to make good decisions about their bodies, their pregnancy. They were still being confronted with this as an issue. And so overwhelmingly in these focus groups, again, despite wherever they fell on the economic spectrum or wherever they came from in terms of their education, they were still being told, oh, you'll be back again because I'm sure that you'll have another baby pretty soon. Or not even really getting a full 5-10 minutes with their doctor, just pushing them in, pushing them out, right? We also talked about the fact that the lack of access to reproductive health care, right, and the lack of access to health care in general is still very much an issue in the South. So this is not just about the fact that we have the ACA, which is great. We're really excited about that. But the fact that Medicaid expansion is not happening in the South still leaves hundreds of thousands of women and families without the access to the health care that they need. That is a very serious issue, right? We also talked about the fact that not only there were barriers to them because of racial discrimination. Not only were there barriers put up because there's lack of access, there's also the fact that we had to dig deeper on this issue, and it's not just about what information you get while you're pregnant, but it's about what information you get before you even decide to have a child. So the fact that overwhelmingly in the South, lack of comprehensive sex education is not the norm. Women are entering into pregnancy, they're entering into their sexual lives without having adequate information about how to actually deal with what the potential consequences could be or whatever that they need to know to be able to make good decisions for themselves. So if we're hitting all of these barriers before even getting pregnant, right, we're going to continue to see issues like maternal mortality continuing to rise in this country. So one of the things that we wanted to do after bringing these groups together and really getting this very raw, very real, just real-time stories from women in the South, we were like, well, now how do we move this forward? We did the report. We were able to bring these stories to life and really start to center the lived experience of these women and what they're dealing with in the South. So how then do we now take this to the next level? So this past June, we were able to convene a really, really diverse group of folks in Atlanta, Georgia, for what we call the Black Mamas Matter convening. And so we wanted to bring around the table not only, our doctors and, healthcare providers, but we wanted to bring doulas and midwives. We wanted to include activists working on the ground, right? And bring this round table together to say, this is an issue that is impacting our communities. And so how are we going to work at this across all of our different movements and how we go about doing this work? And so it was a powerful convening of just really illuminating this issue and really helping us step forward into thinking about how do we tackle this issue from many different angles, right? And so again, this is something that for us, when we looked at Black Mamas Matter and we looked at just the times that we are in this country around racism and how that's showing up in so many ways, Black lives matter, and so do the lives of all of the women who are trying to give birth and have healthy pregnancies. And so for us, this was right in alignment with how that is showing up and how we can really broaden this conversation around Black Lives Matter as well. So I'm gonna stop there because I'm really excited about the question and answer period. But that's how we're taking this approach as a reproductive justice movement. It's about really getting to those root causes of inequality. It's about getting to those root causes of how racial discrimination still very much shows up in this country and tackling it from that issue, because if we don't dismantle those systems, we're going to continue to see issues like this rise, because that's the root and we have to extract the root first. So thank y'all for this opportunity.
Thank you, Monica. I think you said it best when you said this is really bad and really sad. It is, but we're gonna work on it collectively, and we're going to start by doing that through a discussion here in the room. But I do want to say before I turn it over to the audience members, I was hoping that you would speak to beyond the health system. Issues and root causes, and I have to say your examples around abstinence only really were striking, definitely. So why don't I stop talking and turn it over to you all to talk about what struck you and what you want to hear more about. Francesca, I think we have a question here on the right-hand side, or left-hand side for me.
Hi, thank you. My name is Kirsten Stewart. I'm with Futures Without Violence, and we also house the National Health Resource Center on Domestic Violence. So my question is probably a bit obvious with that. If you could, and I'm thinking, Dr. Liu, I know the Office of Women's Health is starting to do some DV work around community health centers and doing more around screening and prevention. So I'm wondering if you could talk a little bit about how that's being linked with other efforts around this particular initiative. And also, similarly, Ms. Begleiter, I didn't see domestic and sexual violence advocates up there, and yet when I look at all of the causes, when I look at substance abuse, obesity, homicide, which is almost always domestic violence, suicide, women's involvement with the child welfare system, that is almost always at its root a childhood experience witnessing violence, experiencing sexual violence. So if each of you could talk, I know Sister Song has been a wonderful partner on this work as well, just sort of about how you're bringing domestic and sexual violence advocates into either payment models or the bigger MCH conversation.
Let's start. Yeah, so thank you for bringing up that issue, and certainly thank you for all your leadership and championing the work around intimate partner violence. And certainly we recognize that this to be an important cause of maternal mortality and morbidity as well. We don't have national studies around the contribution of intimate partner violence to maternal mortality, but we do have some local studies that demonstrate that the contribution of intimate partner violence to this problem. So that's certainly something that we're concerned about. I think in terms of kind of the overall kind of national initiative and approach, there are some areas that I think we can still do a lot better. So for example, in terms of preventive services, in terms of all the things that we're doing around healthcare, I think providers have to do a better job in terms of screening for intimate partner violence, in terms of kind of referral to all the services that the women and the families will need. I also think about the type of the integrated community systems that need to be developed, and so also as part of kind of the broader initiative, it's not just kind of within the healthcare system, but how do you create that system of support in the community that would really help support families and provide that kind of level of support for again kind of women, children, and families who are victims of intimate partner violence. So.
I would urge you to look at the report that's online. One of the recommendations was around intimate partner violence and what we need to do in the systems that interface with women. We have people on the maternal mortality review team who are advocates who work around the issue of domestic violence. I think we all think a lot about it. If you look at the data from this particular report, it was about they knew of IPV in 25% of the cases that were reviewed. I'm sure it was much, much higher than that. So it's not something that we're ignoring at all.
And what about sort of trauma-informed care that addresses the violence and also child sexual abuse, which we know is related?
In the report?
Or in the system?
I think it is mentioned in there. I think that we as a city are doing a lot to try to get providers educated on trauma. We have a long way to go.
And I just want to add one piece for us, because for the RJ movement, it really is about trying to move other movements into understanding like the notion of intersectionality, right? And so the more that we can actually have those conversations from that framework, I think that we'll be able to bring in, how domestic violence, CSA, all those things intersect, with this issue, because it's just so necessary. So that's what we really keep trying to push in this conversation, is for us not to look at it from a single issue lens. Like, it's not just from, the healthcare perspective. It really is about looking at it from a very holistic and intersectional perspective. So, yeah.
Additional questions? I see 3 on this side. So what we can do is collect all 3 and then give you guys a chance to respond to them at one time, if that sounds easier.
Hi, my name is Reem Ghonaim, and I work with Management Sciences for Health. I have 2 questions. The first one is about your, your experience with working with fathers or males in the community and how that plays a role in your programs. And then the second is if you've come across working with other minority groups like Arab Americans, there is very little data on them, and especially with issues of discrimination. There are some studies that were done after September 11th to see that there are bad health outcomes that come for mothers during that time, the research that was done then. So yeah, if you have information about working with members of the community of that background as well, it'd be interesting to see the differences across the different minority groups.
Bit of a timely question right now, too. I think there was a question right in front of her.
Hi, I'm Mark Hathaway. I've worked for many years. I'm an OBGYN. I worked for many years in a large community health center system here in Washington, D.C. called Unity Healthcare. I'm now working more internationally with an organization, JPIGO, MCSP's programs. But I'm continually struck by discussions like this that, at least in our country, that make me sad and somewhat frustrated that, A, we don't see the need for a single-payer system. B, we don't see the trying to just, if we could fix poverty, we might be able to solve a lot of the issues. But since we can't, I've tended to try to focus on things that I can maybe have an impact on, and that's family planning. And many of you mentioned it. However, it seems as though we don't have a lot of national guidance in terms of markers, metrics around family planning. And there has been some positive movement in terms of getting more and more women on more easier to use, simple, effective contraceptive methods. But we still miss that link between helping a woman get herself as healthy and financially, mentally, physically before she gets pregnant. We miss that. So we end up taking care of a lot of women who are unhealthy when they're pregnant, and we try to do a good job. And then, Bet, as you pointed out, the postpartum issues, there's still a lot of financial constraints in trying to get a woman on a good, effective contraceptive method immediately postpartum. We tend to wait till 6 weeks, and we lose a lot of those women. And there's lots of things that can be done before she's discharged from. So the question is, how can we better move national guidance and national metrics and national financing issues so that we are doing a better job of sexual reproductive health prior and during and after pregnancy, as Dr. Liu pointed out. Thanks.
Great, thank you. So, Monica, it wasn't your fault that I thought I said reproductive health earlier. I sensed that question was coming.
Yes.
I think we have one more here on the side, and then we'll give you a chance to answer.
Sorry, great set of presentations. I really appreciate the stats and the community programs and the reproductive justice. Great way to put it together. So it links a little bit with, okay, sorry, Debbie Armbruster, USAID.
Yes.
Sorry, good point. I'm interested in, from Dr. Liu's perspective, two things that I didn't see. I know you couldn't have many slides, but, and you spoke a little bit about geography, the geography of our issue. And you also, in your alliance, I didn't hear you speak to actually addressing disparities. And so I wondered, what was going on with that. So thank you very much.
So if it sounds good to you all, since I think there were an array of questions for everybody, maybe we can start on Monica, move down since the last ones were directed to you, and that'll give you a few seconds to think. But there were questions around male involvement, work with fathers, various minority groups, as well as how to bring about better guidance, finances, metrics on sexual and reproductive health, and then geography and elements of disparities.
So, to your point, sis, I'm sorry, I forget your name, but say one time.
Reem.
Reem. Oh, that's beautiful. I will say that, historically there hasn't been like a direct connection with us working with the male population, right? We've really been focused on, amplifying the voices of women of color. We've been really focusing on really getting the leadership and all that's needed to really move this work with and by women of color. But over the past couple of years, we've been really digging deep on how to best start to step into doing that work and really leaning on our male allies to really help us move that work forward. So it's not a formalized, way in which we're trying to do that. It's just in the ways that the different things that we try to talk about and different issues, we're trying to make sure that our male allies are very much at the table and bringing their voices and bringing their their expertise and all of that to the table too. So it really is very much about like this relationship building and the way that we do the work. So that's not really a direct answer, but it's just a way that we're trying to definitely move that forward within the reproductive justice movement. I will also say that I agree with you. The populations, like Arab American women, that is one of those, and also just like API women as well. Like those are two communities where we are finding that there's so much that we need to learn about these communities and like the issues that are impacting these communities. And we need to get better at that. And I think we need to have a deeper dive and more investment and resources going into that. And it's something that we really try to push when we look at the overarching, movement itself and figuring out where we need to actually do a deeper dive. And that is one of those areas. But it's so hard to get the statistics and the stats and everything on those communities, which makes it hard for us to then build cases and all of that, right? So I think that we want to lean on folks who have, passion and expertise around that to help us figure out ways to make that happen, for sure. Asian Pacific Islander women. Is the community, and also Native American women too. That's another big thing that we talked about at our last leadership institute for the movement. It's like, how do we get more, information out of these communities so that we can actually build better cases to be able to have more support going in and the ways that we need to. So I hope that's somewhat helpful in answering your question. I think there's we have a lot more to do and a lot more to learn how to do it well. And then to your question, sir, about
Family planning.
Family
sexual
planning.
reproductive health.
And yes. You want to say it again? I missed it. Fixing poverty? When y'all figure out how to do that, you will make my job a whole lot easier. But I think what's interesting about the whole conversation of family planning, for me, what I keep seeing in the different rooms that I'm in, is that we have yet to put it all in the same room. Right? So either we're talking about maternal mortality, and then we're talking about contraceptives, and then we're talking about everything in these siloed conversations, and we don't do it, in this very holistic way. And so we're basically we're forcing a way, like we're compartmentalizing women's bodies. Like either you can only talk about my vagina, or you're going to talk about my uterus, or you're going to talk. No, I'm a whole person. And so we have to look at all of these conversations in a very holistic way. And I think that we've yet to do that, which I think is what's adding to this disjointedness, right? That then it feels like we're having to address the same issues over and over again when we could be addressing the big issues under one umbrella of talking about all of these things at the same table. And I think there are many different reasons as to why these are, separated, true enough. Some of them I understand, some of them I don't. But I think that's the issue, is that we've yet to be able to do that. And I'm really excited and I'm really invested in finding ways for us to actually put that put these conversations under one umbrella in a way that everybody's at the table and we're tackling the root causes and everything at the same time. Because I think that's when we're going to start to see some movement, and we're going to start to be able to figure out the better ways to make the different changes that we need to see made, to start to see some progress made in all of our issues. But I don't think that we've done that yet. But that's the beauty of the reproductive justice movement. It's also one of our challenges, because folks say, oh, you all put everything on the table. We're like, yeah, we do, because that's what we have to do. But I think that's the thing that kind of comes up for me in your question, is I don't think that we've been able to do that well yet. Is that helpful? Okay.
I'll try to add to that.
Yes.
You put so much in there. Our model is a home visiting model, and so we work with whoever is in the home when we visit, and really encourage men to be involved. I think a lot, and we have had success in involving men in participating in our intervention, in being there when mom gives birth, and many other things. So I think it's definitely there, and we look for more creative ways to do it. The Arab community does not show up in the maternal mortality statistics yet. And I don't know if that's a matter, for our city, that's a new immigrant population. We are starting to serve more Arab American families.
in our program, but I think we just don't know enough. And a lot of what we do, we're following the data. So where we see there are poor health outcomes, that's where we're going to be working, and we don't see it there as yet. I think it's going to start emerging as there's more in the population. I do want to let you know that one of the major recommendations from the Maternal Mortality Review report was to get better support for long-acting LARCs, contraception, long-acting reversible contraception. I always get caught on that one. And, you know, I think we have to look at what all the disincentives there are physicians to do, you know, to do them, and the way that our Medicaid system is set up. It can't be done right after the woman gives birth, and women have to come back. And, you know, the women that we work with do not see the value in the postpartum visit. And also, you know, if you're schlepping a baby and maybe 2 or 3 other kids and taking public transportation, and by the way, you might be depressed also, it's not going to be a priority. So a lot of attention was put on that, and we actually invited the new Pennsylvania Surgeon General to our review team, and we presented that, and she seemed to feel like that this was something that is fixable. But I do think it's going to have to happen, and I think if we can have it come from the feds that Medicaid has to cover, I think Michael can do anything. Yes. And will you put that in? Right. I think that's such a simple fix.
Yeah, can I just add one piece though to the, because I think this conversation around LARC is important, and I think it's something that we definitely need to do. We have to have more conversation around, because in our communities, from a reproductive justice perspective too, like, we are definitely all about making sure that access to contraceptives is definitely on the table, and something that we want to make sure folks have access to. But the conversation around LARC, like, we're having some really interesting conversations among women of color around this really heavy push of LARC on communities of color. And historically, right, what that has looked like for our communities, and how that then brings up concern for communities of color now as well, right? So I think that this is a very delicate conversation to have in communities of color, and something that we have to be very mindful of in terms of, like, how much we're pushing that, where we're pushing that, and what type of impact that has, right? So for us, it's not just what we want to emphasize is that not looking at, and I don't want to derail the conversation, but not looking at LARC as like the thing that we're like, for everything, but it's like looking at a very, you know, all of the different options on the table, and really having very clear ways of, like, describing all of the different options for folks around family planning, and not just, like, feeling like LARC can be a catch-all. For that is really, really important for communities of color, and I've been having lots of conversations across many different sectors on this issue. So I just wanted to drop that in the room too, because that is very real. It's a very real conversation for communities of color.
Voluntary informed choice of contraceptives.
How about that?
Radical notion.
Well, I just want to underscore a point I think Monica made, which is really a very important point for all of us to understand here, which is if we really want to do something about reducing maternal mortality and really addressing the gaps in maternal mortality, we really cannot keep working in silos. It does coming together. It does take coming together just like this. Can look around this table. Okay? That's what this is going to take. You know, folks working across silos, working across sectors, e pluribus unum, out of many one, and that's what it's really going to take. So certainly it would take fathers and father involvement and father engagement. And some of our programs, for example, our Healthy Start programs in 200 counties around the country has this kind of reinvigorated focus on how do we better engage fathers. We know that they could be an important source of support for mothers, for families, and certainly it does take us really addressing some of the key issues, including family planning and contraception. And we are seeing this coming together of various folks, both the Title X programs, the family planning folks, as well as CMS, the Center for Medicare and Medicaid Services, that are really looking at how do we improve the quality and the content of the postpartum visit, including access to effective contraception. So they are actually trying to do a lot of work. But the way CMS works is that they do work with state Medicaid programs, and it is trying to kind of building that partnership and putting politics and ideology aside, how do we really advance a common vision, a common goal here? And then lastly, I think around the kind of question around disparities, I do think that to the extent that there is differential access to high quality services, that if we can just kind of raise the quality and safety of care for all women, that it will address some of the disparities issues, but we can't stop there. And that's because that we very much understand that there are these social determinants outside of the healthcare domain, including housing and poverty and unemployment and father absence and racism. And again, kind of racism outside of the healthcare setting, operating across the life course, that are the real drivers, the root causes of disparities that we see in maternal and child health, including maternal mortality. And so again, I think the message is that this is not a single problem issue that will just need a simple, quick fix. Right. It really takes all of us coming together, working across sectors and across silos, addressing all of those issues, including the social determinants of health, that will really help us move the needle and close the gap on disparities in maternal mortality.
Yeah, I was just about to say, did anybody want to address that?
Yeah, and there are definitely very much geographic disparities as well. And we, our bureau actually published a report, I think back in 2010, that really demonstrated the huge disparities that we see, both in terms kind of north versus south, but also in terms of urban kind of rural differences. You've already highlighted the increased ratios of maternal mortality in a number of southern states, but what we also see is that there are kind of large urban-rural differences as well, with higher with higher rates of maternal mortality and severe morbidity amongst the kind of women living in rural communities as well.
Oh yeah, for sure. It's bad.
So I do want to open up for another round of questions, but while we wait for my colleagues to bring mics around, I did want to just give some insight around the father's question you asked earlier. So I mentioned it was quite a long time ago at this point, but I was working in Camden City with the Healthy Start Project, which is in communities with high infant mortality rates, and the Planned Parenthood there had a Fathers on Track program specifically designed to work with fathers in communities with high infant mortality, but I do think that you often see those two mortality issues go hand in hand. And that program still does exist. I'm not sure, I believe it's still part of Healthy Start there, but if you wanted some contact information for anybody there, we can chat afterwards.
You know, I just want to add in, that as much as we do, we hear it a lot in our world that we want to get fathers involved. It's still, when we look at MCH, the kinds of things that are counted are not the dads. Mm-hmm. So to count as a participant and as a Healthy Start provider, you're under a lot of pressure to serve 500 people a year. The dads don't go into that number. Mm-hmm. Mm-hmm. So I think we have to look at, right, and I think there are some very concrete things that we can do that will put more emphasis and pressure for those of us who are hustling, quite honestly, to meet those deliverables.
Great. So there's one back by there, and then I think there are two on the side. So why don't we grab these three, and then we can open it back up.
Hi, thanks everyone for wonderful presentations. I'm Tina Johnson from the American College of Nurse Midwives, and I'm really concerned, and we are, along with our obstetric colleagues, concerned about the workforce shortage that's happening in obstetrics. We're working on national legislation to make some adjustments to create a shortage designation so that providers can be incentivized to go into those areas that are most underserved. But another key problem is the underutilization of a full complement of types of providers, particularly midwives, nurse practitioners, and others who are reimbursed currently at sub-Medicaid standard rates to begin with. And as we know, Medicaid rates are already bad. And those are particularly states that are in the most needy regions of the country. So for example, while we are eligible for 100% Medicaid reimbursement under Medicare, still there are about 22 states in the country where nurse midwives are not reimbursed at 100%, and I'm sure that applies also to nurse practitioners who are not reimbursed federally at the same rates. And so how are we know that our type of care can save money and be effective and can improve outcomes. It's well documented in the literature. But until we start reimbursing providers for providing that care and really utilizing that workforce, how can we make changes to address what we know is an impending shortage in obstetric care workforce coming down the pike?
That is real.
Hi, I'm Donna Vivio. I work for USAID on the maternal newborn health team, and I am also a nurse midwife. I practiced here in the DC area for over 20 years in many different situations, DC General up through Shady Grove Hospital, so in many different situations. So I think I know a bit about what's going on and have my own ideas of why. But I want to first of all say I applaud having global health people here together with domestic people, because we do not work in silos, and I think we can learn from each other around this. For example, in terms of postpartum family planning, in the global arena, we are doing a lot of talking around healthy timing and spacing of pregnancy, so that's a message, as opposed to limiting your family or starting later, et cetera. And in addition to figuring out ways to get at that missed opportunity of immediate postpartum family planning. And that doesn't mean forcing anything on anybody, but really giving them that information along their lives so that they have an option to, to make the best of the opportunity that they have, while they're in the hospital or whatever kind of birthing facility that they're in. So I applaud that. But I have two questions. One is around the bundle for preventing unnecessary cesarean section. I'm sort of interested in what that might look like. And I know it's in development right now, but also when that might be ready. And then the second is related to your program, the Medical Care Coalition program. And that just sounds like heaven, to me, sort of how you're really dealing with systems issues, et cetera. And just wondering, assuming that everything is going well and that you have really great outcomes, how that might then play out in terms of not just your program. How might that get scaled up either in your city or elsewhere? Because, again, in global health, we are finding that as a big issue. You may have great programs, but then, once the money is pulled out or, once you're onto a bigger platform, you just don't have the wherewithal to continue.
Was there one question next to you?
Hi.
Did you have a question earlier? Oh, okay, great.
She was the one.
Oh, okay.
Hi, I'm Kathleen Hill, and I think like a few of us in this room, I also work domestically and globally. I work actually in the community health system that Mark talks about. I'll be at the clinic tomorrow. And I also work globally with the Maternal Child Survival Program funded through USAID. So I do a lot of work in very, very high mortality, low resource settings. And I also want to echo, I think this is a wonderful panel because we're really seeing sort of the full picture here. And I think that's a recurring theme that I'm hearing, bringing together the different pieces. And I wanted to address and perhaps ask a question around also following up on some of these quality bundles. I think think that we're now seeing in global maternal and reproductive health, a hugely increasing emphasis on quality of care. And particularly, although we talk about it, one of my concerns is that we are going to, or that we may miss opportunities to really focus some of the quality of care work around equity issues. So really systematically looking as part of our quality improvement in service delivery settings at the degree to which quality is varying by, different characteristics depending on the settings. Because I work globally, sometimes it's race, but sometimes it's, ethnicity, or it's, it really depends on the context. But certainly in this country, very much is around race. And so I'm wondering if that, and maybe this is a question really for all of you, is that something that you, Dr. Liu, in terms of this maternal health initiative that is being systematically looked at? It looked like you were pulling out data very specifically from California. Is that something that's being done systematically as part of this? And can we learn from some of that and really also take it into the global? Because there's a lot of work now, I'm thinking of the quality of care framework at WHO now, which really hasn't gotten into disparities and equity issues, but really from my perspective should. And I think, there's a lot of sort of cross-learning that can occur here.
So if it sounds good to you all, it looks like we ended again with a question towards you. So if we want to start on that end to give you a few
I'm going to
minutes.
start with the doctor because I think there's a lot of doctor that was going directly to the doctor. But there are things I want to add. But I just think the last two questions were very much centered on answers that he can give directly.
Sure. Do you feel, do you need a few minutes? Are you good? Okay.
I'm good. I'm
Okay.
good. So I think, first of all, around the issue of nurse midwives and so forth, I do think that we are in I think historic time in our healthcare system right now. There's a lot of movements around both payment reforms and around delivery system reform that we do have an opportunity to figure out how do we make our system smarter, healthier. And one of the things that I know part of the work of this initiative is kind of looking at appropriate levels of maternity care, right? So we know that not all women need very high risk care. That some women could be better supported with more appropriate levels of care. And so, how do we can make sure that we design a system that promotes that type of systems integration? We've been talking about perinatal regionalization in this country for over 30 years, and when the idea first came up, more than 30 years ago, it wasn't just about NICU regionalization, but it was really about the whole more comprehensive in terms of not just the neonatal but maternal levels of care. And I think that's the issue that a number of us are now revisiting. How do we make sure that women get the best care, the appropriate levels of support? I came from working in a system at UCLA for about 15 years, where we had that type of care, and we worked very closely with the team of midwives as well, and kind of recognizing that there are certain things that the high-risk specialists do better than the midwives, but there are a lot of tremendous care that the midwives provide that the specialists weren't providing. And so how do we design a more integrated, more comprehensive system that really address the needs of women and families, but also make our system work a lot more efficiently, a lot smarter and healthier. I think in terms of some of the global examples, and I do think that there's a lot that we can learn from the successes of the work of USAID and others around reducing maternal mortality and morbidity in many of these countries. I've been very much impressed by the approach that's been taken, setting clear aims, and having a clear set of strategies, and clearly understanding what what success looks like, what's the metrics of success, and being able to really kind of deliver that. I think there's a lot that we're really trying to take from the global lessons and apply to what we do here in the United States. And certainly, a number of things that you talked about are the kind of things that I think this type of global exchange would be really helpful. And I do think that the focus on differential quality would be an important focus, especially when we're talking about addressing disparities in maternal mortality and morbidity. We know that there's differential quality going on, both in terms of inside the hospitals, but also the more comprehensive care around. So and it's figuring out how do we develop both kind of the aims around not just the overall outcome, but the disparities in the outcome. It's having a set of clear strategies that address the disparities, because the strategies to improve the overall outcome may be very different from the strategies that focus on addressing inequities in outcomes. And then again, having clear metrics in terms of measuring and tracking our progress, again, not only just to lift up the outcomes, but how do we reduce the gaps in outcomes.
Did you want to make any comments around unnecessary C-sections, what that bundle looks like, and when it would be ready?
Yeah, so I do think that we know that there are still kind of C-sections that really shouldn't occur. That they are really not medically indicated, or that they result from poor management of labor and delivery. And if you want to kind of look back even farther in terms of poor management of kind of preconception health before women enter pregnancy. So I do think that there's a lot of things that we can do to reduce cesarean delivery. I'm going to go ahead and put this question over to my colleagues over at the American Congress of Obstetricians and Gynecologists. Again, it's they're leading the effort, but the effort is really a collective effort of a lot of different partners, including the American College of Nurse Midwives, AWON, and Merck for Mothers, and so forth. There are lots of folks that are kind of working on this, and I know that they've been working on developing this bundle for reducing cesarean.
Can we wait? If you want to make a comment, can we get a mic over to them, Francesca?
So I'm Jean Mahoney, and I'm the director of the AIM program at, we are housed at ACOG, but we are utilized through the Council on Patient Safety and Women's Healthcare, and I think that that's a big piece of this. We do have a C-section bundle. It is out. It came out last month. It is on our website, which is safehealthcareforeverywoman.org. And I think that as we are talking about many of these issues, that you may want to look at that website, particularly if you hit on AIM. You'll see that a lot of the issues that we've been discussing, we're talking about. We're talking about them not just at the OBGYN level, but we're talking about them with midwives, with nurse practitioners, with patients, with payers. I'm sorry, thank you. With hospitals. So it's not just that we're sitting there as just individual providers and saying it's somebody else's issue. We're looking at our own stuff, because one of the things that we found when we looked at maternal mortality, and I hate to say it, but about 50% or more of the maternal mortality issues that are preventable are provider issues. And I'll just say that right across the board. We understand that, we know that, and we got to look at it and fix it. We also have a special work group that we have just begun, so it's just starting, and we would love to have Monica involved with it, is our disparities. So it's really looking at looking at peripartum racial disparities and making sure that, number one, at the hospital level, at the birth level, that we can look at things in a little bit more data-driven way, because we can look at outcomes that happen with practice. And those are the things that we really need to push this along. Once this work group gets underway, which is just starting now, we're going to be able to look at some of the issues that we may not have been thinking about in the past, particularly the communication issues, which I believe are probably the major issue there. We have found that, interestingly enough, that if a white woman delivers in a hospital that has predominantly black births, that her outcomes are very similar to the women to the black women at that hospital. Whereas if a black woman delivers at a hospital that has predominantly white births, her outcomes are very similar to the white women. It's an NIH study. It is just being written up now. I can't give it to you, but I can tell you that that's what the findings are. And I think that that's a very important place to start. And so we are looking at those hospitals.
Thank you.
I want to just add to this the issue of quality of care. I bring up the mortality team a lot because I learned so much there. But we would do case after case, and we had one doctor who was quite a character, and he would say, well, there was nothing I could do about it. And this has nothing to do with the hospital. And over and over and over again, that would happen. So I want to add to the issue of quality of care is whose responsibility is. If the social determinants of health are what's killing a lot of people in Philadelphia, I know it's not just Philadelphia, then what's the responsibility of the healthcare system? So that when you have these quality of care task force and initiatives, you need to bring other people to the table. And, you know, the new flavor in America is community health workers that global people have known for a long time.
We still don't do it as well as we should.
That is true, but there are people in this country who are doing it well, and we have much to learn from our global friends on how we could do it better. And actually at HUP, they have a community health worker initiative there where they're putting them into a lot of different services and doing data on it that shows that it actually changes outcomes. So the silos are killing us. And I think we're all guilty of it, so I'm not going to say healthcare is any different than anyone else, but we have to have more people at the table, and we have to think about, you know, one of the cases we had was a woman who had a seizure disorder and was a substance abuser, and she came in quite ill, they got her better, they gave her a referral to come back for all sorts of testing. You know, I know it'll be a big surprise to all of you that she didn't come. We need to put more in there if we want to prevent deaths.
Did you want to talk a bit about scaling up?
Yes. So one of the reasons that we partnered with HUP was that they are an academic medical center. We actually are unusual for a community organization. We actually have a research director, and our first one was Heidi Worley, who's sitting there. She left us for DC. But we feel that we have this period, thanks to Merck, to really test this model. And so we are working very hard to be able to demonstrate outcomes that show that this is a model that can work so that it is scalable. And we also, at the same time, are trying to see how can we make it sustainable. And that's the efforts around getting Medicaid coverage for things like community health workers, doulas. This is, what we're doing is literally saying we're going to try this on 100 chronically ill women every year. And if we can make this work, then the hope is that with all these people paying attention, we can make it something that will be available to more women.
Yeah. I just want to add one quick piece to the conversation. I was just on another panel talking about maternal mortality from a reproductive health and rights and justice perspective, and I shared the panel with an amazing midwife. She's based in Florida, and she's created this model talking about how to, it's kind of like a scaling up situation too. It's called the JJ Way, and I'm not sure if you all are familiar with that. You can Google it, it'll show up. I don't want to talk about her work because it's not mine, but what she was, the premise of her work is like, how do we get more midwives and doulas of color really working within our communities? And that's something overwhelmingly that we've seen in the South. We have some amazing midwives, amazing doulas, but not very many of them really that are able to like really be out in the rural communities, really working with women, with families. And we're seeing that that is really, it's hard. And I feel like if we were able to figure out ways to increase that pool, that actually gave, that gives these women of color what they need to be able to do this work well within their communities, that we would actually start to see a huge decrease. But I think that I was just also at the International Center for Traditional Childbirths Conference. ICTC is the name of the organization, and they work with midwives and doulas of color, Black women in particular, and that was one of the major conversations, is like, are we a dying breed at this point, right? Where are we? Where are we? And so I'm really excited to think about those ways that we can like work with the partners around this table and out there, to think about how we can start to see an increase there and scaling up there as well, because I think that's also going to help us start to decrease this issue as well.
We can do this.
We can actually do this.
We're doing it. We're training community doulas in Philadelphia. We've trained over 60. We've matched them with 400 women who couldn't afford to have a doula, and then we give them a stipend. This is grant funded.
So we need this in the South too.
But it's a we can share that model. There are women out there who want to do it, and they go through it's a 20-session training program, and I was like totally I said, there's like no way women are going to hang in through these training, and we're in our 3rd year of doing it, and we lose like 1 a year from the training. People want to do this.
They do, and we have to like push those folks who are funding this type of work to invest across the board and to like make those dollars drop, in the places that they need to drop. And I'm excited about your model. I want to talk about how we can move that model into the South too, and to get the resources necessary to make those things happen. But for folks, and this is where we have funding disparities, right? So when we look at programs, projects, organizations, led by folks of color versus not, sometimes we do have some disparities there. And so I want to like close that gap and like learn from each other and work, across the board, come out of these silos so we can get this issue it's when we can take it out. Like, it's not even that hard if we just sit at the damn table together. It's not that hard. It's not.
I think part of the problem
so you need a mic. No, you need a mic though, because the webcast can't hear you.
I was just going to say that, the South continues to have the problem with equity in licensure and regulation of people who are not physicians and who can provide these services. And we can't get the Black midwives down to practice in Louisiana until there are systems in place that will recognize accredited education, license people, and then allow them to practice to the full scope of their education and training. And we're up ahead of the game here in the Northeast, but the South lags behind, and we need to pressure the colleagues down there who are blocking us, who are blocking legislation, and who are blocking allowing people to come and practice in their hospitals and in their communities. We need an active, concerted effort to educate them and to systematically remove the barriers that are preventing those people from practicing, because they're real and they're existing even in this day and age when we need those people so badly.
I'm so with you on that. Yes.
So if you all haven't already heard, CNN is launching a series tomorrow on giving birth in America, and I wonder a bit, I don't know if Jackie, you wanted to add anything more to that, or Katie, if either of you. If so, can we just get you a mic? They can't hear us otherwise.
So tomorrow on CNN.com, Every Mother Counts is launching a 3-part series called Giving Birth and with Chrissy Turlington. So as you may know or be familiar with some of their work, it's been primarily global. But like many of us here, want to shed a light and start working on these issues that are happening in our own backyard. And so please tune in to hear more. They focus on a woman of color who's a midwife in Florida and runs her own clinic. They focus on a woman of color who's a doula in New York City, and then also a rural woman in Montana who is pregnant and is facing geographical barriers to access. And while I have the mic, I thought I would just add that at the Maternal Health Task Force, just today we launched our new topics page on maternal health in the U.S., so it has just a huge collection of resources and background data on these issues, especially focusing on the inequities, the deep inequities in our country. In addition to that, we have a blog series that launched a couple of weeks ago, so I invite any of you who are feeling, which I hope is everyone, because I can feel the energy in this room, who's feeling just really moved by these issues and what we need to do next to write something for us. We'll get it published, we'll work together, we'll hear what everyone has to say and how we move forward together. Thank you.
And thank you, Maternal Health Task Force. I mean, you all are the reason we're sitting here talking about this. I mean, and I do really want to say thank you for that. So we actually, I don't know if there's any more pressing questions. What's going to happen is those tuning in online, that'll cut, but we can continue, or we have lunch available for everybody right outside the room, and so we can continue more informally over lunch if people prefer, or I feel like I've seen 2 here if we want to grab these last 2 and then do lunch. Does this sound good? Actually, I'm going to say last 3 because I'm going to add one too. And since I'm still talking, I'll keep going. And that is, one of the things, like I said, when I was thinking through this panel was and I think we've touched upon it here or there, but just around data collection in the States. What are your thoughts about how we're doing in that regard? And, if we need more progress on that, what can we do until then? Mm-hmm. Okay, and then I think there's 2 more here.
Okay, since I have a mic. I'm from southeastern Ohio, from a small town, officially Appalachia. It was a college town, so it was a little different. But we're talking urban here. And I remember that I went to CASE when I started to school, and they had a perinatal network. Probably the beginnings, that 30 years ago, when they were actually trying to deal with the rural areas and bringing them in. But I'm not hearing a lot about what's going on for that group. They're losing facilities. They have no providers. You've got meth problems. You've got all kinds of other things, poverty, et cetera, lack of access. So it's a very different world than urban settings. I mean, clearly, lots of issues in urban settings. But who's working on that and what kinds of things are happening? Thank you.
And then one more here.
Hi, Mark Hathaway again. I'm following on your question and perhaps best directed at Dr. Liu, and I know you're not completely connected with the birth registry information, but I'm curious if you feel that the system we have now really gets, or is it robust enough so it really gets at the issues that are perhaps quality issues, provider issues at X hospital in rural Georgia or urban hospital in New York City that's perhaps very different than another urban hospital in New York City. So I'm wondering, and then also the skin color is one component, but it's probably more important that we look at social economic status versus skin color. So I'm wondering if you feel that the birth registry or the system that we have for collecting data is robust enough that really gets at how we can drill down and figure out where the gaps are.
Yeah, so I think in terms of the data question that you raised, the birth registry, question that you raised. I'm not the best person to address this, but certainly I know my colleagues over at the CDC, at the National Center for Health Statistics, are really kind of looking at it. And I know through some support from Merck for Mothers, they are working with a number of states in terms of seeing how do we collect higher quality data at the state level in more real time, so we have a better understanding, kind of a snapshot of what's really going on in the states in real time. So a lot of those kind of work is going on right now, but there's definitely room for improvement. There's still this whole notion of not just collecting the data from birth or death certificates, but a more comprehensive picture of what's going on, which I think comes from efforts like the maternal mortality review efforts that are going on in many parts of the country. And do we kind of want to have a kind of nationalized system to do so? I know in other countries they have a national inquiry into maternal mortality. Is that a system that we should be moving toward, and so forth? So those are ongoing kind of active discussions right now amongst various partners in terms of the need to make sure that we have clear data about what's going on in this country and how can we do better.
And any additional thoughts on rural communities?
Yeah. So yeah, I do think that the number of the issues that drive maternal mortality are shared by both urban and rural communities, but rural communities definitely have their own challenges, including kind of access. And certainly when you think about some of the major drivers of maternal mortality, like hemorrhage and preeclampsia and thromboembolism and so forth, some of those really important quality issues, and how do you address obstetrical complication when it's occurring? In urban settings, you have hospitals, tertiary centers are equipped to do that. In many parts of the country, in rural communities, you don't have the specialists right there. So we got to figure out a smarter system to deal with this. And I know we've been supporting a number of efforts in terms of connecting the rural providers with specialists in the cities through telehealth, telemedicine model in many different areas. And there is kind of ongoing conversation whether that model might also look, what that model might look like in terms of making sure that no matter where you give birth in this country, that you have access to the best care. But it does require us to work a lot smarter than what we're currently doing.
Any finishing thoughts or concluding remarks from either of you?
No, I think I'm good.
Great. All right, so let's eat. But before we do that, actually, I just want to encourage us to have these conversations over our meal. I also wanted to encourage you to visit our website and our blog, newsecuritybeat.org. Come back on the 30th to hear more about non-communicable diseases. And thank you for making this discussion great. And join me in thanking our speakers. And Emi Shia.